Okay, we're ready to start. So I'm just going to share my screen for a second to show what we're going to be talking about. All right. So this article, I'm Ira Kirschenbaum. I'm the editor of the Journal for Orthopedic Experience and Innovation. This article came out of nowhere. 1,050 views. 1,050 views. Truly a remarkable tribute to the authors, to the product, and to what they wrote and the interest that it gathered. Just to give you an idea, the average article in Journal of Arthroplasty gets 67 views. So for this to get 1,050 views and 43 PDF downloads is absolutely remarkable. The authors, Kaylin Strausser-Curtis, Chris Varacallo, Voss, Stevens, and Captain. Is that right?
Captain. Yep.
Captain did an amazing job. Chris, why don't you just tell me a little bit about what got you interested in doing this study? I mean, because you're in practice in mid-Pennsylvania, right?
Mm-hmm.
And this made a splash that makes the Rothman Institute articles look benign.
Well, thank you for that. And yeah, it's an exciting topic for sure. I think it identifies a treatment gap, and that's probably, one of the reasons it garnered a little bit of attention, because it's something that we all deal with in our, orthopedic practices and even general practices, musculoskeletal medicine. We're seeing elbow tendonitis and tendinopathy quite frequently, and outside of corticosteroid injections or, non-insurance covered treatments, orthobiologic, shockwave, prolotherapy, needle fenestration, not really significant treatment. So I've been doing these ultrasound guided tenotomies for about 8 years in my practice. And just a little background on me.
Yeah.
I'm a primary care sports medicine physician, and very handy with the ultrasound, in my own opinion. And that's just from a lot of practice and a lot of treatments. And so I really had a lot of these patients land in my office with, not really many other options for them. They maybe saw one of my orthopedic surgery colleagues, and they, didn't want to operate on them, or didn't feel like their disease was severe enough, but they landed in my office because they had some issues with activities of daily living, their functioning, just their quality of life in general.
Right.
And so as I was practicing, my treatment options is, I do some conservative treatment, some rehabilitation, maybe some splinting, maybe a counterforce strap, and then a corticosteroid injection. And inevitably I saw those patients return, in 2 or 3 months with the report that they felt amazing for 6 weeks or 8 weeks, and their pain returned. And so, talking about other things, I'm in a little, it's not an underserved area, but we have a disproportionate share of Medicaid. So, then we started talking about orthobiologic injections. Can we do PRP? Can we do, some type of amniotic allograft, something like that, really to treat this? Or are we just doing a corticosteroid injection? And so many of my patients said, I can't really afford, any, non-insurance covered things. So let's do another corticosteroid injection. So then we injected them again. And really a similar story, or, even less relief. This time it worked for a month. And then I see them back in 3 months and they say, yep, I felt great for a month. And now, 2 months of pain and decrease in my function activity. And what else do you have for me? And so this was actually introduced to me a year or two into my practice as a treatment option for chronic tendinopathy. And just over the years, really trying to learn more about tendons and tendon pathology, this treatment option really makes sense, because a lot of the times what we're treating is not, tendonitis, so to speak. It's more tendinosis, where you're having, degraded, damaged collagen fibers in that tendon. And a lot of the treatment options we have don't address that pathologic tendon tissue. And this is a treatment option that really is aimed to address the resection of that pathologic tendon tissue, much like, an open procedure would, but we can do this minimally invasive with ultrasound assistance to identify the structures. And really that tendon tissue looks hypoechoic or black on ultrasound, where it should look, kind of bright white or grayish and organized fibers. That tissue really looks degraded and degenerative on ultrasound. And this is something that a treatment we can, take and utilize to debride that bad tendon tissue, that degenerative tendon tissue, and lead to some pretty good outcomes for those patients.
So I noticed in the article that you had a wide indication base, someone who failed the PRP or failed the cortisone injection or failed this. What was the number one treatment that most people had? Was probably, it looked like it was corticosteroids.
Corticosteroids, I mean, anyone that practices, musculoskeletal medicine, we rely heavily on those corticosteroid injections. And, when we started designing the study 7 years ago, we knew less about tendons than we know now. And corticosteroids, even from a provider standpoint now and even patient standpoint, a little scared or a little nervous or basically resigning to the fact that, we won't want to do corticosteroid or even anesthetic in and around these tendons a lot of times because of some of the catabolic effects that can happen. So yeah, corticosteroids obviously are pretty popular treatment. Patients love them because they give them, quick relief. But really they land back in our office with recalcitrant symptoms most of the time after we do these injections.
So I got out of the OR a couple of years ago. I had both of my knees replaced, but as I like to say, I still identify as a hip and knee replacement surgeon. But in my office, I see general orthopedics, something that I started my practice with and something you sort of end your practice with. And I sort of kind of put them into three categories: the irritant problems and the problems that we know we can solve with a scalpel. Yeah. And it's actually amazing when you don't have your PAs see, all the non-operative, and you see it yourself, that you see Achilles tendonitis, Achilles tendonopathy, patella tendinopathy, greater trochanter, up to their fifth injection from somebody. And then you get an MRI, and then you hope maybe it's a gluteus medius tear, so you could operate and put a biopatch on that or something of that nature, right? What other, you're not speaking for the company, so you could speak anything, any level. Do you see any limit on any parts of the tendinopathy, the enthesopathies, that this can't treat?
Yeah. And so I'm just speaking from personal experience and just having thousands of these, minimally invasive tenotomies under my belt. It's really something that there is not a limit. I mean, obviously, to your point, you identify a great treatment gap, and a lot of my colleagues, my brother's an orthopedic surgeon, sports surgeon, that does a lot of the, arthroscopic or, sports related surgeries, as well as some arthroplasty. And, we pair well together because anything that he sees or his APPs, his advanced practice providers, see that falls into this tendon category, tendonitis or tendinosis, kind of gets shoveled my way because we have a good treatment in our practice. But you're absolutely right. I don't think there is a limit. And, from the glute med, that greater trochanteric lateral pain syndrome, to the Achilles, to the plantar fascia, the patellar tendon, quad tendon, calcific tendinopathy in the shoulder, this device actually takes care of those issues. And, if you have a greater than 50% tendon tear, you kind of set and level expectations where, if you're 85 with a partial tendon tear, okay, maybe we're talking about doing something like this. If you're 30 with a partial tendon tear greater than 50% tendon tear, we're talking about, maybe repair or something like that. So it's a nice addition to many orthopedic practices to have someone that's skilled in administering these treatments, because it keeps those patients, in-house and under your own roof, and it allows them other treatment options other than corticosteroids or biologics or physical therapy or bracing and things like that.
Tell me a little bit about the results when they're successful. How long does it take? Do you see it immediately? Is there a lot of pain after the procedure?
Yeah, That's a great point, because that's what we're talking about with a lot of the patients, and we're trying to set expectations with this. So it's a little deceptive for the patient, and we all talk to patients and we have these discussions, and they retain a variable amount of information that we deliver to them. But it's a little deceptive in the fact that we use an 11 blade, we make a stab incision on the skin, so we close it with steri-strips most of the time. So it's a little deceptive in terms of a patient looking at the procedure they have done and expecting a fast result. And sometimes it is, but most of the time what it does is it follows general, a healing cascade in general, where, for the first 2 weeks or so, there is some discomfort and maybe some increase in the post-procedural soreness, maybe a little bit above the baseline. So in that phase, the first 2 weeks or so, we're really protecting whatever area that we've just worked on with the minimally invasive tenotomy. And then over the weeks 2 through 6, there's usually a general progression of improvement in symptoms. A lot of times by week 6, we're talking 80 to 85% improvement in a lot of these patients, but not all. And the whole time we're meeting with them at 2 weeks and 6 weeks, typically, either myself or one of my PAs or even my athletic training staff. And we're discussing this return and this return to functioning and recovery. And that 6 to 12 weeks is really when we garner a lot of those residual, maybe improvement patients initially. Week 6 to 12 is really where that sets in. The advantage of doing something like this is we protect them for about a week or two post-procedure, but then after 2 weeks, we're really not cutting them loose, but allowing them to get into a gradual return to activity based on their symptoms and what they're feeling. So I always explain to patients, hey, you're doing this procedure for a little faster return to activity. That's a double-edged sword, where you can do too much too soon, but you can also, do too little. And so at week 2, typically when we see them in the office, we're allowing them to advance some of their activity as pain allows. And then week 6 and week 6 through 12 is typically when we see a lot of the bulk of the patients in that bell-shaped curve. That's when they're really responding to these treatments.
Superb. Kevin, you had a question.
So, Chris, it's great to see you and appreciate it. Unfortunately, I've written a lot, and I'm curious. The Swiss said years ago, all you have to do is stick a needle in the elbow, cause some blood flow, and suddenly, because it is a watershed area, I know anything will work. So yes, we inject steroids, yes, we do all this other stuff, but someone did a study and they just poked the needle in and they got the people with the same result because they got blood flow to the area. The British, I'm an old codger, I visited a guy named Sir William Wadsworth. He has this battle axe of a nurse. You go into the back room in a soundproof room. He takes your elbow, he rips it to hold it straight, to rip the fibers, because most people have partial tears. The British typically go, oops, an American would scream. He throws an ice pack on it, and suddenly now he says, oh, you'll be better, now go away. So I think TenJet is Tenex, the old Tenex, or is that different?
It's a little different. Actually, it's a lot different.
Okay, so how Tenex and Bernie Morey, if you wouldn't mind, is a little different than TenJet, and how we're not doing, we evacuate I agree with you, it's a tendinosis, we've written about that. So how does that differ then in the two?
Yeah, so you highlight, just to kind of circle back to your initial point, you highlight a good point, because, I always liken this to, how do you treat a wart? There's like 100 different ways to treat a wart. That's because there's not one definitive, perfect way to do it. There's a lot of different ways to skin the cat, so to speak. And so that's really where we're coming into identifying which tendons are going to be best treated with which technologies. And so, when you see this degenerative tendon, a lot of people that do ultrasound don't look at, other factors with ultrasound. Very easily, you can throw on color Doppler and see if there's any hyperemia or neovascularity that's happening. Those types of tendons can respond better to maybe some of the injectables or biologic treatments versus a tendon that's completely degenerative that, if you throw color Doppler on, there's no blood flow, no neovascularity there. And we're just talking about a degenerative condition. So I think, to your point, is there needs to be a little more research. How Tenex and TenJet differ is Tenex is more oscillatory and basically shaking and debriding that way with very little aspiration component. There's saline that's infused to cool the needle tip because it gets pretty hot with the oscillation. And so the Tenex actually floods the area with some saline, cools the needle tip, actually distorts your image as well when you're performing ultrasound. So you kind of lose that hypocoque, and really the quality of the tendon gets distorted while you're doing the procedure. TenJet, conversely, pressurizes saline through a double lumen, and actually in the inferior lumen it gets pressurized, and then through aspiration there's a cutting window at the distal end of the tip that actually, through the velocity of the saline, creates a negative pressure called the Venturi suction effect that actually resects this tissue and actually collects it in a canister that is actually physically removed from the body. And then the other part of that is you're also needling that tendon as well while you're performing the procedure. So
Here you go.
TenJet differentiates itself is it's actually performing resection and needle tenotomy and fenestration together in one kind of, very easy to use device that we can accomplish a lot of different things. But to your point, I think we need to better classify tendons. And then also, as we are classifying these tendon pathologies better, we can actually recommend more effective treatments for these different types of tendons, because, a degenerative tendon, you're going to treat a little bit different than a hyperemic tendon with degeneration versus just a straight hyperemic tendon with hypervascularity.
Thank you.
Thank you for the question. That was a great question.
It's interesting. Alejandro Badia uses Tenex, and he put together this video, which I'll show. It's not what you use, but this is how he describes it. Okay. Hopefully you can see my screen now.
Yes.
Yeah.
I want to draw it out so people understand. So if you look at his arm, okay, so here is a tip of that very prominent bone right there. And the patients, usually have pain there. So this is muscular, and then this is sort of tendinous. The tendinous gets diseased, right? So people come in with MRIs and they say, oh, my tendon ruptured. No, the tendon doesn't rupture. What it is it's degenerative. So on an MRI, it looks abnormal, and as it does on the ultrasound. So what we used to do is make an incision from here to here and go through skin, go to the muscle, elevate the muscle and the tendon origin and scrape the bone and scrape the tendon. And that works, but you can imagine that that's painful post-op. And for somebody to go back to tennis or golf or manual work, that's very difficult, very painful. So it takes a while. These people can go back. I mean, I have tennis players going back within about 3 weeks because instead of opening and scraping this area, I'm going in with a little hole and a device, right, called the Tenex, right? It works on the tendon, and it's got a little oscillating tip, and that vibrates ultrasonic. It's ultrasonic energy that then basically liquefies a bad tendon and aspirates it, suctions it out, which is why you probably don't have pain, because the chemicals that really stimulate
All right.
the brain perceives as painful, called cytokines, they've been suctioned out. So even when you do the open surgery, many times that's still there. But
So I will stop the share. Is that about accurate there, Chris?
Yeah, I would say that's a nice description, and that's what you're really getting at. I'll just add that the TenJet device actually suctions a lot better than the Tenex to remove that material. But I think some of that saline flush is part of the success of Tenex. And I started using Tenex when I first started doing these tenotomies, and then it really shifted to the TenJet because I, anecdotally saw some improved results and some faster recovery. And I think it's that resection piece that is the missing component.
So just one slight correction. In Joey, we don't believe in anecdotes. We call that experience. We call that experience with innovation.
Yeah, exactly. You're right on.
Otherwise we'd be JOA, which would be the Journal of Anecdotes. But the JOA is already.
I like it. By another I stand corrected.
You stand corrected. You got to use the term "in my experience" in using this innovation. So let's talk about the big question, which is a little bit of the multi-pound gorilla on the wall. How do you get paid for this?
Yeah, so that's a good point, and that's one of the things that over the years of doing this, really the descriptors are important in describing what you're actually doing in dividing and resecting tendon. So from a personal opinion standpoint, I do feel pretty strongly there needs to be some dedicated codes for these procedures, which there are not at this point, and that's where utilizing some of these, avenues to have some peer-reviewed research is going to be helpful. But essentially, there are a lot of different coders and billers that have kind of different interpretations of the procedural description and the approach and everything like that. And so some will settle on, this is actually a tenotomy code, and others settle on, well, this is more of an enlisted code. I think it can distinguish itself. You're actually resecting tendon using this device and degenerative tendon tissue, and you're dividing it, and you're essentially getting to that pathologic tissue through tendon division. And so a tenotomy code I do feel is appropriate, but there's some billers and coders that disagree with that. But I think, to your point, I think we need more peer-reviewed research to really maybe then present to the AMA that maybe we can get some separate coding and reimbursement guides too.
Yeah, and also to AAOS clinical practice guidelines.
Absolutely.
To look at it. They mainly look at, spinal stenosis, osteoarthritis of the knee. It's just a tendon. Which fills my office. We have 1.125 million clinic visits in the South Bronx, of which 1.12 have tendinopathies. Yeah. And
I think we're about the same in Central Pennsylvania too.
Right.
Right, exactly. You're right. There's this fills offices. My practice is extremely busy, and I don't do arthroplasty, and I don't do rotator cuff repair, and I don't do ACL reconstruction. I don't do partial meniscectomies. But my practice is extremely busy to the point where I have 3 procedure days a week where I'm doing a lot of these procedures. So it's something that really I've kind of developed a niche in my area where I can take care of these problems. I take care of them effectively, and we get good patient outcomes and self-referrals that way. I have people coming from states away to have this treatment done because there's not a lot of providers that do it. Right.
So again, I'm going to push the cost a little bit. What is the cost to the facility to start?
The cost of the facility for the console and the equipment, you mean?
No, not the part B, for the equipment. Assuming you have the ultrasound already, you have the setup, you have the nurses, what is it? What is the raw cost?
Yeah, so from a facility side and purchasing the equipment, the console can be a few $1,000s. It all depends on like any practice, how much volume you're doing can kind of decrease your costs and everything like that. But the console is reusable. It is a plug and play type of technology into the console. So your needle tip is your device is disposable, and that can run anywhere from $500-$600 up to $1,000. Or more sometimes with some of the tenotomy devices that are on the market right now. But that's what you're looking at. And then, cost facility reimbursement for using tenotomy codes is certainly going to cover the cost plus extra with that. Yeah. So it's a reasonable thing. If you're talking about, taking care of these patients and decreasing costs as well, just overall, burden of healthcare, I do all these under local anesthetic as well. We don't have to recover them in the PACU. We're talking during the procedure. It takes me, essentially less than 5 minutes to do it. And, they're driving themselves to and from the procedure many, many, many times. So in terms of, anesthesia costs and nursing costs and, recovery PACU costs and all that type of stuff, those are eliminated a lot of times.
So I want to mention, we're at the halftime point. Oh my God, look who has joined us.
Yes.
Oh my God. Alejandro Badia. Alejandro, are you there?
I just texted him.
Oh,
I'm gonna say
The show.
no surprise there.
With him.
Yeah. So there you go. Alejandro, we just showed you a video of the Tenex. I don't know if you could.
You're muted. You're
Yeah.
muted.
Yeah. Yeah, sorry.
We just showed the YouTube video of
Right.
the Tenex.
No, and I said you guys had already discussed a paper on the hydro ablation.
Yeah, that was Chris
Option.
Varacallo's. I want to know your experience in treating, just using this kind of technology, whether it's Tenex or TenJet, your overall experience and patient satisfaction with this.
You know, I've never run the numbers, but I'm going to say it's at least 90% good to excellent. What I will tell you, the frustrating ones are the occasional ones who aren't much better. And I think a lot of it is patient expectation. And then there's a few outliers that just like don't have any relief. And those are the ones that, you know, maybe I'll try PRP, maybe I'll give them a little cortisone injection. And there's just people that it's just resistant, you know. But the beauty of it is, if, for example, if it doesn't work that well, is that it's almost completely painless procedure and post-op. And the fact that you can use the arm, you know, literally right away. I mean, I let my athletes, tennis players, golfers and stuff return back gradually at about 3 to 4 weeks. I mean, with open tenotomy, I mean, you all know the inertial procedure that, you know, it hurts for quite a while. So that's my experience. I mean, it's in line with, you know, Bernie Morey had a paper really mostly with a Singapore before they had FDA and all they did a study, and I believe it was so 86% good, excellent. So kind of in line with a lot of the other techniques, but just less painful and faster. You don't burn any bridges. You can always do something more aggressive.
Yeah, that's a great point. And then those recalcitrant ones, that's where you're kind of looking at, why are they recalcitrant? Is that tendon, have neovascularity and hyperemia? Is there something else you need to do? Did you overtreat, the tendon? Did they flare it up in the recovery phase, or now they have a tendonitis on top of, tendinosis that you maybe addressed, with your procedure? So yeah, that one, that 10 to 20% that maybe is recalcitrant, that's, some focus now. That's kind of where I really looking a lot of times at why we have 10 to 20% that aren't responding when we have great response out of the majority of patients. And like I said, there's probably some subclassifications of these tendons that we need to shed a little further light on, and then really elicit some treatments toward that.
So I would recommend to both of you, I've used Tenex, Alejandro, it's Kevin Blanchard, that you get, Kevin. I know you're both very proficient in the ultrasound. Go get an MRI. Look for the dead tissue, really see the whole briefing of it. And that may teach you, because you both have the experience, why those are recalcitrant. Exclude your workers' comp, because I agree. I've had some failures in workers' comp. Okay, no surprise. But I agree.
Couldn't be.
Surprised. So, but I mean, I can get, 90%, and I've used the Tenex, whatever it is. So it's interesting. Take an MRI. You might be surprised that you have a full thickness tear already, and that isn't going to help with what you're doing, and you got to go in and do some sewing. So.
That is true. And at that point, if I've done enough of these where if I see them at 6 weeks and I can kind of sense where it's going, there's typically an upward trajectory. If it's not resolution at 6 weeks, there's an upward trajectory at 6 weeks. But if we're status quo or we're worse than we were pre-procedure, it's either, some sort of, inflammation. The history tells you the whole story. I felt great, doc, for 4 weeks. And then, I played, tennis, or I painted my wall, or I did all my guarding or whatever, more than I ever had before. Okay, maybe you have a little tendonitis on top of things where you flared up during the recovery phase. But usually at that 6 weeks, without a history like that, where they were feeling great and maybe aggravated it, an MRI is extremely helpful at that point. And that's where I start looking at that cross-sectional imaging to shed a little more light on why they're not part of that 80-90%.
Yeah.
Great point.
Yeah, but aren't you worried that when you get the MRI, the patient reads a report and it says, "Oh, right, doc, you got it."
Absolutely.
So that's kind of why I shy away from the MRI, because I'm just not sure it changes. But it sounds like Kevin is suggesting that, if you see that
that big gap or something like that, do you actually have to go in? Do you actually repair it, Kevin? I mean, do you?
Yeah.
You have drill holes and anchor. What do you use?
So I want to go backwards to scare a little of you. I never go in without, I don't own an MR facility. I want to make it very clear, okay?
Okay.
Don't make a penny. There's never been a patient in my life on an elbow that I never got an MRI. First,
Wow.
because I want to classify them that this is America, that either the MRI is normal, and so you can blow on it, you can put some air on it, and it's going to get better, and it doesn't matter, and they're going to get better. The other ones are, it's a complete tear. They're going to surgery right away. And 95% of them are the partial tears that you're talking about. And so I want to classify the patient right away, what bucket they're in. And I can dispense with the 2 buckets, the ones that have no tear whatsoever, and say, I don't care, use a Bandit, smell on it, gives Epsom salts. I don't care what you do because you're going to get better. The full thickness tear, I'm going to repair. So what I do, I don't do inertial because I was trained by Jim Strickland and those guys. So you see, we actually take the rongeur right off the lateral epicondyle. Another day, I'll tell you, Alejandro, what I do, but it's in the Indiana Hand Center. And so that's what I do. And then I do the Tenex, like you said, with the 95% with the ultrasound. Plus, I want to bust the healthcare system. So that's great because I'm now stifling it. So it's great.
So I'm gonna push Alejandro and Chris. Why isn't a TenJet, for example, or a Tenex or with this technology? Why doesn't every practice have this? I mean, I'm thinking to myself, I have a non-operative, an MD, an MD who operated, got out of the OR at a young age because he just didn't want to do big cases, and now he's doing procedures and a variety of things. And I'm thinking to myself, am I missing the boat here in our clinic? I mean, what is there any reason not to have this in your armamentarium?
So in my opinion, there isn't really a reason. I mean, if it's something and you rely on MRI, it's something that if you don't know ultrasound, that's a big limiting factor for ultrasound diagnosis and just intervening with the ultrasound, guiding a device or a needle to a location with accuracy. When you utilize an ultrasound, the beam, the ultrasound beam is 1 millimeter thick. And so when you have a 1 millimeter thick ultrasound beam and you place it on somebody and the probe's actually, the footprint of the probe is wider than that, it can be very frustrating when you're trying to guide to a location and you look at the ultrasound screen and you can't see your needle. And so it takes a little, hand-eye and motor coordination to learn that, but the reps help with that. And the elbow, more superficial in area, utilizing ultrasound in the elbow, you're laying your device more flat, the sound waves are penetrating and bouncing back and reflecting back to the ultrasound probe. And so there's more to come back. And so it's a little easier to see, it's more superficial. And so you can start with something like an elbow and really get proficient with that. You can pair that also with MRI findings and ultrasound findings. So, as you're getting good with ultrasound, you can actually, look at an MRI and then look at a tendon under ultrasound and really correlate those findings together. Throw on Doppler, utilize that. You can actually scan in, short and long axis, cross-sectioning and in long axis as well, where you can actually look at that tendon in a lot of different planes in real time. You can also, activate that tendon and see, what type of, firing that you get, when you're injecting with lidocaine, you can actually elicit some partial tears just by diffusion of that liquid into the area. So, it takes reps like anything in medicine, but I think one of the major limiting factors in terms of getting this into orthopedic practices is that skill and knowledge with the ultrasound.
Really?
There are specialty in primary care sports medicine and non-operative sports medicine is becoming more and more popular. In terms of, training programs and things like that. So there will be, more and more physicians. This is part of our training program in fellowship. So there'll be more and more physicians coming out that are familiar with ultrasound and then working alongside, sports surgery fellowships. A lot of these programs are paired together. So there'll be comfort both ways. So I do think this should be in every orthopedic and musculoskeletal practice, but there are limiting factors with that'll probably, resolve with time and more training. But if that's something that people are looking into doing, I think, throwing an ultrasound probe on a tendon. And if you have an MRI, kind of looking at the MRI, comparing that to what the tendon looks like. If you're doing joint arthroplasty and cuff repair and ACL reconstruction and partial meniscectomy, maybe this is not something that, you're interested in, you're going to take the time to learn. But if you have somebody in your practice that, maybe is seeing non-surgical patients, this is something to really, push them into learning ultrasound and kind of bringing this to the forefront of the practice so you can keep these patients in-house and treat them effectively.
Alejandro, what do you think?
Yeah, well, I think part of the problem is us, surgeons are a bit more dogmatic, right? The physiatrists and pain guys and all, I think they tend to be more open-minded about trying new things, and obviously they don't get to do the surgeries that Chris just mentioned. So these procedures are more appealing to them. And I think they're just more open-minded. And in terms of the orthopods, I mean, Kevin can tell you, I would say that us hand weenies are the most dogmatic compared to maybe the sports guys. So I can tell you the Tenex penetration in the hand community has not been great. I think it's just going to take time. And I think eventually, but the fact that this is minimally invasive, non-painful, seems to have great results. It's just a matter of being open-minded enough to try it. And I think that's just time.
Yeah, we're kind of tipping the iceberg here a little bit. There's some people that do it and have done it for a long time, but majority of musculoskeletal physicians, either don't do it or haven't heard of it or don't know how to do it. And you saw that with the views you mentioned at the top of our recording that, the views in this are pretty substantial. It's because it is a treatment gap that we're looking for options. And it's an appealing thing to kind of say, hey, what's this about? And, what kind of results are we getting and who can do this and how do you do it?
I try to, when I counsel young surgeons, residents, fellows, people who are going to see this video, when we publish it, one of the lines that I have right of authorship is never let a patient unsubscribe from your practice. All right. Never let a patient subscribe. Yeah, you can unsubscribe from a mailing list unless it's a Joey mailing list, then you don't unsubscribe to that. But don't let a patient unsubscribe. And these diseases like tendonitis, like a torus fracture, like a patella tendonitis, an Achilles tendonitis. You treat those patients, you own them, you own the family, you own the cousins, you own the brother, they all come in for everything. And then grandma comes in for the total joint replacement. You dismiss patients and dismiss their disease and don't treat the diseases in your community. You get people to unsubscribe from your practice,
Yeah, so Ira, you're suggesting that because tennis elbow's kind of a nuisance and all that some people kind of brush them. Yeah, I've seen that, and those are the kind of patients sometimes I'll see in my practice. And you have to be patient with them, especially the ones that don't do well, because there's no surgery; it's 100%, right? So when they don't do well, it's frustrating. But at least you can say to the patient, "Look, there's not a big scar. You didn't have a lot of pain. Let's see what else we can do."
Yep.
Yeah.
Yeah, to your point, that's great though. These musculoskeletal conditions run together, and if it's not in the same patient, it's in a family member or friend or somebody like that. And adding this to your musculoskeletal orthopedic practice is a nice thing because, like I mentioned earlier on, I work with my brother. He does sports surgery. He does arthroplasty. We share a ton of patients. And he does things, differently than I do. We tackle a lot of musculoskeletal and orthopedic conditions together, and we refer back and forth all the time for different conditions that we treat best.
So Ira, ultrasound, OSAT, be there.
Right. That's a good segue. Kevin Planch is here, and I do have a video about OSAT, but I'd rather, Kevin, you talk a little bit about the course this year, where it's going to be. Orthopedic Summit, Evolving Technologies.
So I'm totally biased. But I would say that Chris doesn't realize he's going to be there, but he didn't realize it. So we offer 7 different courses in one. individual tracks, whether you're a shoulder arthroplasty surgeon, whether you're a knee surgeon, whether you're a spine surgeon. And I think that there's also a PANP and sports medicine, non-op, and there's a full day ultrasound course that's being offered. It's all one price because we really believe in making a difference in your practice. And when you leave, you better have been treated really well. And I treat my industry partners because without it, we just really try to break even. They are very kind to us. We're over enthused. We're sold out exhibitors, and we really can provide the greatest, newest technology that helps you in your practice, just like Chris is talking about tonight, Ira.
Yeah.
And Ortho Summit can really bring something. So you leave Monday, you're going to change something in your practice that's going to help your patients do a better result for you. And so we're honored to entertain you also. Boston, Marriott Copley, September 20 to 23 this year. Hope to see David there from Avanos. And the point is that you can find anything you need within your discipline, whether it's spine, trauma, hip, arthroplasty, knee sports, shoulder, that will allow you really with great discourse. So don't be surprised if someone walks up to Chris and says, I think you're full of baloney, and wants to say it. And he has to be a big boy to defend his position. And he's ready. You can see how smart he is. And he has science behind it, but that's what we believe in. And so we have to have a little entertainment, and you got to go back at it. And men and women fight on the stage. And if they don't, they're actually not invited back. You also have to be on time. And if your talk is 1 second over, your microphone goes off, the screen goes black, and you're talking to nothing. So that's the point. And I think it's high energy. And I invite you all, and I want you to be critical because it's for you and it's for our patients, most importantly. Thank you.
Hands down, the best meeting in musculoskeletal health there is.
How much did I pay her?
Well, the good news is that I just offered Chris a job in the Bronx, so he's just going to take the Amtrak
There you go.
up to Boston. It's, you got to leave the brother thing, behind.
Yeah, that's all right. We only get along sometimes.
We have a big family in the Bronx. So I want to encourage anyone who may have some questions for Chris or Alejandro. I have a bunch more. Where did you guys learn your ultrasound? Where did you learn your ultrasound?
My
I was, go ahead, Chris.
Oh, okay. Sorry to interrupt you there. So it was part of my fellowship in sports medicine. I actually selected, so I was a sports medicine fellow in 2015. And so I selected my fellowship based on access to ultrasound because I viewed ultrasound as kind of the wave of the future for a lot of this stuff, procedural and otherwise diagnostic. And so the ultrasound I went to is University of South Carolina, and we had our own personal ultrasound as fellow. And so I basically took that and I scanned every single thing I could, a lump on, a thigh, a tendon, a joint, anything I could. And like anything in medicine and life, it's the repetition and just doing it continuously over and over and over again and asking why and what is that and learning more. It really got my kickstart in fellowship and then just in practice, the same thing.
Alejandro?
I was inspired I was faculty of a niche hand course in Girona, Spain, near Barcelona, and a young guy from Barcelona gave a talk, a hand surgeon, on ultrasound. This was maybe 15 years ago, and I said, "Holy cow!" And I came back and I got a sonosite, and then I did, and then I also took a course with Don Buford and a number of other people. So Don was doing a course. I'm pretty sure it was in the Miami area, so it's pretty convenient. And I did it, and it was very helpful. And then it's just a matter of doing it after that. I've also invested. It goes on a blink once in a while, but I invested in this augmented reality. So I'm wearing a headset when I'm injecting, and I'm looking right. I'm almost superimposing the ultrasound image on the shoulder, on the wrist, and then the patient can see the ultrasound, but I'm not turning my head, So that's been pretty cool. So I do most of my injections with that technique.
So Don is leading the ultrasound course, but Chris is going to.
Perfect. Yeah, he's very good.
So
One of the
who-
other things too is, you think for your practice, the cost is a limiting factor, and you can have ultrasounds that range, there's 6 figures for some of those IR, consult units. But now, as the technology is improving, there's ultrasounds that are less than $5,000 that you can pair with a tablet. And for some of these superficial structures are more than sufficient. I have one that I take to my training room for my college coverage. I'm scanning, just connected to a tablet and looking with a handheld ultrasound. So, there's a wide range of costs to these, but you can get pretty high quality images for not as expensive, like it was 15 years ago. You can get actually some good imaging for not as much capital investment.
To be very practical, what company you recommend for ultrasound now? A good price, a good low end, because we don't have any ultrasound companies here on here, and people want to get started, right? They want to get started. They don't want to spend $35,000 for a sonosite, or could they do a butterfly, which we have that attaches to an iPhone, What's the for the TenJet, what's the lowest common denominator ultrasound you think you could get away with?
So I have sonosite units that, like you mentioned, it can be 35, 50 grand. And that's based on the probes that you're using. But I also have a V-scan from GE that has 2 probes on one handheld device. It's and I don't have any relationship with an ultrasound company, so I'm just saying this just from demoing and using. I reach out to the company. I say, hey, I want an ultrasound. This is the price point I'm looking at. What do you got? And then you actually can scan and look and do things and demo it in real time. But the GE V-scan is a nice one that was less than $5,000. It attaches to a tablet. It has a curvilinear probe. So basically, basic ultrasound, the less frequency sound waves, the deeper the wave penetration, but less clarity. And the higher the sound waves, the more superficial the penetration and more clarity. And so it actually has a mid-range straight linear probe, and then a curved probe that's for deeper range, in one handheld device that you can actually toggle and flip based on your tablet. So that's been really convenient. It's a nice starter, I think. It's going to be difficult to get really deep structures in central Pennsylvania. I don't know where anywhere else. We got a lot of subcutaneous tissue in our lateral hip patients. And so sometimes that's a little challenging, but for elbows and superficial things like that, it's more than sufficient.
Alejandro, you agree with that kind of ultrasound approach?
Well, I have most experience with Sonosite, and I haven't been that happy with them because when you have a problem, they charge you for the motherboard, and they're not. I just have found them not to be real collaborative with the clinicians. I don't know why. At some point, especially for our Ortho Now centers, it's kind of almost a requirement because for injections and all, we do a lot of those. We really would prefer that. I don't know if Chris, have you seen the Clarius? I haven't used it, but I don't know
I've
if it's
seen that. Yeah, I've seen that, and I demoed it. It's the same type of thing. So the Clarius, the butterfly, the V-scan. I have demoed it. I went with the V-scan over it. I think anyone that's interested, if you contact major ultrasound manufacturers, Sonosite, GE, Konica Minolta has units, Samsung. You contact your local rep, or the hospital has a local contact. You ask them, give them your price point, and tell them you want to demo devices, and then you kind of go from there. You can really see what you like and what your preference is and what fits for your practice based on your cost structure and all that. But demoing, I highly recommend that.
Okay.
Yeah. So one final question for both of you. You may answer it the same way. So I have, like I told you, I have a doctor in my office who is a non-op musculoskeletal, very, very adept at ultrasound. Where does he go to start learning how to use the TenJet? I mean, are there TenJet training centers? Do we take a trip? Now, no offense, Chris, but I'm taking a trip to South Beach, Miami, instead of Central Pennsylvania. But it's a crapshoot, and I just picked one randomly. But what do you recommend? Traveling to somebody, or are there TenJet courses? I mean, just, you know.
Yeah, so,
where do you go where do you start? Because you don't want to start your first patient with the rep in the room, you know?
Right, exactly. And it is beneficial. So there's not distinctive training programs, but reaching out to the company, Hydrocision has TenJet, reaching out to the company and kind of plugging you in with either resources that you can talk to, or depending on your level, you know, someone that's near you that you can actually observe doing these cases. But I think starting just getting comfortable with ultrasound is a good place to go, and then advancing to guiding needles to structures that you're maybe going to treat with the device. Because honestly, I think the progression is, if you can guide a needle to a location, let's say you're doing a corticosteroid injection for tennis elbow, for instance, if you can guide the corticosteroid with a 22 or 25 gauge needle, whatever you use, to that area, you're going to be able to guide the TenJet device to that area. So I think a nice in between in doing that is purchasing the ultrasound and then just guiding some of these treatments to the location, and then contacting the company to really, you know, kind of see if there's someone close to you that you can observe some cases or things like that. There's a lot of resources that Hydrocision has as well in terms of procedure videos and rehab protocols and all that type of stuff. So you can find a lot of it online too, but I think your next step in terms of learning ultrasound and performing TenJet and these needle-based tenotomy procedures is guiding a needle to a structure in terms of the lateral upper condyle. We talk about that. And then if you can guide that 22 or 25 gauge needle there, you'll be able to guide the device there as well.
Yeah. Alejandro?
Well, I participated once in a little course that Bernie Maury gave down at the Mark Institute, you know, literally a mile from me. But I will tell you, it was really disappointing. I mean, how many people, you know, many colleagues from the local area came to you know, to hear Bernie. I mean, I would come just for that. But you know, the best way is to really do a little lab at the academy. He did, or was it? I think it was the academy. He did one of those little breakout industry sessions with I think with a cadaver arm. Sometimes people have done it with you know, a slab of beef or something, just so that you get oriented with the probe and get the feel of it. But I think it really helps to do a lab. I think that these companies need to do more of that if they want to get people using this. I think they've got to set up labs. I think it's a worthwhile investment for them. I've tried.
I'm watching. Oh, sorry.
Yeah. No, I was going to say that, you know, I almost wish I figured out, gotten some people together to buy it myself, but the Tenex, you know, wasn't a private equity company had taken it over, and they really weren't doing much with it. And now it's Trice Medical. And I've had this ongoing discussion with them of like, guys, there's a lot of people, whether it be Tenex or TenJet, you know, there's enough room. I mean, it's enthesopathies are a $10 billion niche. So there's enough room for those two and a few more. You know, we remember the Topaz procedure, right? So I think it's a matter of doing more courses. Yeah, that would be my desire. And you know, question is, can you entice industry to understand that the benefit it is and getting surgeons to show up?
Yeah. So I'm going to leave this with a couple of comments. First of all, I want everyone to look at Alejandro's office, where his shelves are so good they can hold all 5 volumes of Campbell's Orthopedics and not bend the wood. Which I think is phenomenal architecture there. Chris, I want to thank you so much for coming on, you and Alejandro and Kevin. We learned a lot. There's going to be a lot of lessons for a lot of surgeons who see this video, a lot of takeaways, sort of what we talked about earlier tonight. Don Buford, myself, Sharif Pashai, Kevin talked about the great thing about OSET, you take away things. And I hope people who joined tonight and who will see this video and listen to the podcast took away something about what it is, a very exciting and underused technology. So maybe, Chris, you want to just make a couple of last comments and we'll call it.
Yeah, absolutely. Well, first I want to say thanks for having me. This was a lot of fun. I speak a lot to my my non-surgical or my non-operative colleagues about this type of technology. So it's really fun to speak with you guys, get a different perspective on it, and yeah, really kind of share things. I'm all for what Kevin said. When we are critical and we really delve into why or why not we're doing things, that's how we all get better and we all benefit, and technology improves and treatment protocols improve, and standard of care improves for the good of the patients. And then the second thing is, you touched on it earlier, Ira, just keeping these patients in your practice is an important thing. And typically, if I talk to one of my surgical colleagues and they say, oh, I inject this tendon and it gets better, and they don't ever come back, well, they're not ever coming back to see you. They're coming back to someone like me to do the definitive treatment most of the time with this. So it's something that's a nice addition to orthopedic practice, and we can really work symbiotically together to really, treat these patients better and be champions for their pain relief for these, nagging nuisance type problems, but they are life altering and life changing sometimes. So once again, thanks for having me. It was a blast. I had fun tonight, and hopefully we can publish again and do another journal club again soon.
Yeah. All right. So I want to thank everybody, and we'll say good night. All right.
Thank you.
Thanks,
Have a good night, everyone.
Good night.